including the optimistic, rational exuberance. I also have Courtney Joslin from the R Street Institute. Courtney leads R Street's birth control deregulation research initiative and works on occupational licensing issues. Courtney's research is focused on occupational licensing, prison reform, and other state policy issues. And finally, I have Krista Drobac, Executive Director of the Alliance for Connected Care. The Alliance is an advocacy organization advancing telehealth and remote monitoring policy at both the state and federal levels. Krista has worked on Capitol Hill, at CMS, the Illinois Department of Healthcare and Family Services, and led the Health Division at the National Governors Association. Thank you all for being here today. There's been a lot of conversation around telehealth and how it fits into the fight against COVID-19. Obviously, you can't intubate someone via telehealth. So Michael, would you mind giving us some opening remarks on how telehealth fits into our current public health crisis?
Sure. Hi, Ariel. So, telehealth has always been in sort of hanging around in the background here. The ability, all of our delivery models up to now has been more in person, and there's been a reluctance to embrace the fact that some portions of healthcare can be done remotely, both for cost reasons and also for accessibility reasons. And what we've discovered is that when push comes down to shove, that a lot more of the screening, discussion, and so forth can be done online, whether or not it's physical, mental health, behavioral, optical. I'm not sure how much of dental can be done online, but I could be wrong about that. Okay, but we as with other areas like education, we're pushing the boundaries, discovering really how much our technology allows us to do, and when we come out of this, we'll be able to actually, with a lot more confidence, figure out how we can make telehealth more accessible to people and also use it to reduce the overall costs.
Great, thank you. And Courtney, I know you've done a lot of research around how occupational licensing can impede access to services. Can you talk a little bit about the hurdles to accessing telehealth services?
Sure. So occupational licensing has become a really interesting issue during the pandemic, just because of the way that it's radically affecting how people can access healthcare in times of crisis. So two of the things that I want to focus on for how occupational licensing is affecting people's ability to access telehealth services currently are license reciprocity and also the scope of practice. So for license reciprocity, what that is, if you are a licensed, let's say, registered nurse or a pharmacist or a doctor in one state, and you move to another state, your license doesn't very easily translate most often. So what that means is, let's say you're a doctor in Tennessee and you move to California. You then have to go through California's licensing requirements for physicians, even if your license in Tennessee is in good standing and you met the exact same requirements, there are still hurdles to jump there. So in times of crisis, license reciprocity is really important. And what that is you have the ability to work in other states if you have a license in good standing in another state. So in this case, if the doctor was moving to California, his license would sort of automatically roll over in a way, so he would be able to practice as soon as he was established there. And again, this is something that's important anyway. We see license reciprocity affecting people's ability to work. One very pertinent case is in the case of military spouses. So military spouses have a very high unemployment rate, often because they work in licensed fields and because they move around a lot and their licenses don't apply. And the process of getting one in a new state is very onerous. So, you have this in normal times, but again, in the time of the pandemic, the ability to work across state lines is even more important as we're sort of allowing our supply of healthcare workers to more easily shift to wherever the demand is. So that's one of the major issues with licensing currently. And the other is scope of practice. So scope of practice obviously refers to what you legally can do with your license. So this is something that I've been working on a lot. is looking at where are we not allowing medical professionals to practice to the full extent of their training. And we see this a lot. So there have been some pretty innovative reforms in the last few years for scope of practice for professions like pharmacists, for example, and this is something that we've worked on a lot. So pharmacists now in about a dozen states can prescribe birth control directly to patients. And this is because it's a very simple process for prescribing it. It's pretty straightforward, and they are trained to do this. And so allowing pharmacists to prescribe things like birth control are good, again, in normal times, but in the times of a crisis when you may literally not be able to go see your doctor, or if you're not able to talk to your doctor via telehealth, the ability to go to a pharmacy to get your prescriptions is really important. And so allowing for some scope of practice reform for professions like pharmacists, again, like nurse practitioners, physician assistants, registered nurses, all of these people, giving them the ability to do more and then allowing them to do more using telehealth means that more people can stay at home and still get the level of care they've been getting before the crisis. So that's something that I think we'll see a lot more of, hopefully, in the coming months and years in terms of reform, is allowing more medical professionals to do more for their patients.
Thanks, Courtney. That rang true to me. I actually had a prescription expire and was able to renew it over the phone, which I hadn't done before. So that resonated with me. And so I know the Trump administration has taken a number of steps to make it easier to access telehealth services. Krista, can you explain what's happened so far and whether or not it's enough?
Yes, a lot has happened. And in fact, they have been acting in many cases on the authority of Congress that was given them by Congress. So really is a joint effort. Congress gave the Trump administration the authority to waive the restrictions on reimbursement in Medicare. So you no longer have to be in a rural area or in a designated facility. You can be anywhere and treat patients, and the patient can be anywhere. And the reimbursement is essentially one-to-one. It's as if you were in the office. So in addition to reimbursement, they've also addressed technology and privacy. On the technology side, they said that a smartphone is permissible, so you can use audio only, but it has to be able to be enabled to use video. There was a lot of consternation about that because providers are saying sometimes our patients only have a phone. So they did add 2 phone-only codes. Those are just E&M, treatment codes. And then on the privacy side, they waived some of the HIPAA requirements for telehealth platforms. So you can use FaceTime and Skype, which are not HIPAA compliant during this crisis. Congress the DEA waived their prescription requirements around controlled substances. So you can prescribe controlled substances by telehealth. And that's mainly for treatment of behavioral health. On the commercial side, in the large group market, there are 32 million people who have HSAs, and you can't have a health savings account and receive free or discounted telemedicine services. It's considered other coverage. So from now until the end of December 2021, people who are HSA holders can receive from their employer or their health plan free or discounted telemedicine services. That's just a few of the things that have happened at the federal level.
And then is that, do you think that's enough, or is there more to be done to increase access?
To be honest, they have done so much that, I don't really think there is a whole lot more that needs to be done. They've done, some of the smaller things like for remote patient monitoring, which is, not the real-time video visits, but the monitoring of biometric data remotely. So like a glucose monitor, for example, they waived the copays on that. And they also waived the requirement that you have an in-person prescription for that. So those are other examples that every time we came up with a barrier, they addressed it. So they put out multiple guidances. We're expecting one additional guidance that is the result of the third package. But, you know, everything we can think of, like, for example, physical therapists, occupational therapists, speech therapists were prohibited from providing telemedicine. And, you know, this administration and Congress together fixed that. So, yeah, there's not a whole lot more that we need. Now we just need to gather the data to try to make this permanent.
So can I ask a question here?
Yeah,
Okay.
of course.
Isn't it, you know, I was sort of looking, you know, that the question is, what kind of data can smartphones collect? Okay, that they've been sort of discouraged from collecting. Is there issues around there that are kind of more FDA issues?
Well, when the FDA, when the first glucose monitor was approved for reimbursement under the durable medical equipment rules, they said that you could not collect data from an iPhone. That the device had to be, you basically could only collect data from the device. Well, everybody complained because most devices nowadays connect to your phone because that's how patients get information. So they changed that rule in 2019. So the devices for remote monitoring could collect data on the phone. The telemedicine piece of this, there's actually two parts to it. One is the reimbursement part, and the section of the Social Security Act that governs telemedicine payment says video, audio visual. It says audio visual. So I don't think that the Trump administration thought that they could that they had the authority to make it audio only. This third piece of legislation actually allows the Trump administration to waive in its entirety that section. It's 1834M of the Social Security Act. So they could conceivably now do audio only, and they could in this next iteration of guidance. But also I think there's a second part of this, which is that the states are the ones that set the standard of care. So when we're talking about federal policy, we're only talking about reimbursement. We're not talking about permissibility.
Right.
And many states do not allow audio only. So even if you could get reimbursed in Medicare, you would still have to abide by state laws around what is permissible in terms of technology.
So it becomes the state laws that are more of the problem at this point.
Yeah, but 49 states have waived licensure requirements. Most states have waived existing relationship requirements. You know, the states are waiving an enormous amount too. And on our website, connectwithcare.org, we actually have a COVID page, and we have resources there that are updated every day around what states have waived and also what they're doing with their 1135 waivers.
And that brings me to my next question. Courtney, so it's obvious that the states have a huge role to play in the delivery of telehealth services. What have they done either during this crisis, and what is still sort of left to do in order to increase access to telehealth services? And Courtney, I was hoping you could answer this one.
Sure, yeah. So as Krista mentioned, we're seeing a lot of change on the state level literally every day surrounding telehealth. And something I want to expand on that Krista mentioned is the existing provider-patient relationship. So typically before the pandemic hit, if you were to use telehealth services, there were a lot of requirements depending on the state you're in that you had to have an existing relationship with your provider, meaning that you had met them face-to-face before you could initiate in telehealth services. And now, obviously, that's not possible if you don't have a relationship with a certain provider. So a lot of states are waiving those requirements, as Krista said, where now you can use telehealth to establish that relationship. And we're seeing various other things that are coming into play. As I mentioned, with license reciprocity being a problem, a lot of states, governors are issuing executive orders relaxing licensure requirements. So basically, a lot of them are saying that, you know, if you have a valid license in another state, you're more than welcome to come here, and you won't be penalized for working in our state if you have a license elsewhere. So that's been really important that we've seen. We've also seen states allowing for different kinds of telehealth. So in Arizona, Governor Doug Ducey actually issued an executive order allowing for televeterinarianism. And so you can now use telehealth to get your dog or cat or other pets checked out, which is kind of cool. And we're also seeing executive orders around the use of the various uses of telehealth for things like synchronous and asynchronous telemedicine. So for this kind of goes back to what we were talking about earlier with the audio and or audio video requirements. Those are synchronous telemedicine. So basically, right, if you're FaceTiming your doctor or Skyping your doctor, that's a real-time interaction and that's synchronous. But if you're talking about asynchronous telehealth, which is the store and forward method, basically that is you're entering in relevant medical information, you're undergoing any necessary tests, and then that information is captured via a website, and then that information is then forwarded to a physician that's licensed in your state for review. And that, since that's not a real-time interaction, a lot of states have had kind of murky rules around allowing asynchronous telehealth, in some cases outright bans on it. But what we're seeing is a lot of states are opening this up as well. Maryland Governor Larry Hogan just signed into law a bill that does allow for asynchronous telehealth. And that's been really important. We've been kind of using the Maryland legislation as an example of what states should do in this case. And so, there are two states have a really important role to play. And I think the important thing to remember here is that we're seeing a lot of executive orders being issued around this stuff, but those are temporary. And so what we do want to see is more legislation that's making these changes more concrete, like in Maryland. So the ability to use telehealth services is great during a pandemic, but we need to be able to use these telehealth methods beyond the crisis, so that we're more flexible, we have a more robust system. And so we're really hoping to see more legislative changes, not just these executive orders that are being issued, relaxing licensing requirements, relaxing, like I said, the audio video requirements, relaxing the bans on any certain form of telehealth, so that we can get, the most people the care they need as quickly as possible in an innovative way. So we're hoping that more states are going to look at more long-term solutions than the executive orders being issued.
Definitely. And then just because sometimes when you talk about these things in like an abstract concept, asynchronous would be like if I had a mole and I took photos of it, or like I needed to renew my contact lenses or something like that. So that would be something that you could do on your own time and then send off to be reviewed by a professional before you.
Exactly.
Okay. Got it.
Exactly.
Well, Michael, I know that broadband access is spotty in some areas. And obviously, if you're talking about, either audio visual or asynchronous where you're trying to send high resolution photos, can you explain what infrastructure would be needed to get telehealth to everyone?
Well, so I think actually this sort of bears on the discussion we were just having about synchronous versus asynchronous. Synchronous, which requires video, requires higher broadband and is actually more stressing to the infrastructure, and so we'd actually have to make sure that in this rural areas of the country have better broadband. That would be pretty important because accessibility is one of the real benefits of telehealth. To the degree to which we can use more asynchronous or lower bandwidth telehealth, including just audio, it actually is something, it puts less stress on the system, so that it's a chicken and egg problem here. We're actually looking at some of the rural broadband issues. We want to make sure that this is something that gets accomplished as we kind of go forward to sort of build the infrastructure that we need.
Yeah, I can't imagine right now when we're all working from home, if you were in an area that didn't have high-speed internet and trying to do what we're all been doing. It's kind of crazy to imagine. And then circling back to you, Krista, what can be done? You've sort of talked about from the legislative perspective, but is there anything from the federal regulatory perspective that can be done to increase access to telehealth services? It sounded before, like you said, from a federal perspective, we've done as much as we can. Can you just elaborate?
Yeah, we really had a chicken and egg problem before the COVID pandemic, which was if Medicare wasn't paying for it, then physicians weren't investing in it and weren't offering it to their patients, so therefore patients weren't trying it. And if you look at the commercial market, mostly telemedicine is happening through vendors that work with employers and health plans, and so you're not really seeing your own physician in that case. But now that we have people who are trying it, which is really the big hurdle. Once people try it, they like it, and the patient satisfaction surveys are already coming back really positive, which we all as telemedicine advocates knew would happen, but we just didn't have the ability to get people to try their first telehealth visit. So just to give you some numbers, our members, one of our members, Intermountain Healthcare, used to do 100 telemedicine visits per week, and now they're up to 10,000 a week. At Stanford Health, another one of our members, less than 1% of all care was delivered through telemedicine, and now 70% of all care is delivered through telemedicine, and they're doing 3,500 visits a week. And American Well is doing 30,000 visits a day. So if you think about it, now we've got all these people who have tried it, and it's really it essentially translates into a new benefit. And so I think access to telemedicine will increase if we can make these changes permanent, at least the reimbursement changes, because suddenly there will be an incentive to offer telemedicine services, which will then provide people with more access to it.
And then on that same note, I wrote a blog post. It's not published yet, but it'll be up later today around, I know that there's been a huge increase in mental health services being delivered via telehealth. Can you sort of touch on what types of care make sense for telehealth and what types of care do not? And Krista, you can answer that, or Courtney.
There are some types of telehealth services that require what are called peripherals. So if you have CHF, for example, if you put on weight, if you have CHF, it's extremely dangerous. It's a sign that that you're having complications. So some people have remote scales, that can send weight to physicians. Another type of peripheral is if you have chronic ear infections and you need to look in your ear, you can buy a device that connects in. So yes, behavioral health and primary care are great examples, because in a lot of primary care or urgent care situations, you just need the patient's history and the patient's symptoms, and you can generally figure it out. Where some more complex diseases, you would either need some sorts of peripherals or basically a mix of virtual and in-person care.
Yeah, and I think it depends, but renewing prescriptions, I know that I'm not the only person that's been in that boat during this, where all of a sudden your prescription is expired and you can't go into the doctor's office. And so being able to, update your health information and send photos or whatever is necessary remotely is key, either for things like, just ongoing prescriptions or contact lenses or all the things that we have that require an annual renewal.
I will just add to that really quickly, Ariel, that just want to kind of emphasize what you both have said, which is that there's so much, quote unquote, low hanging fruit that I think telehealth services are letting us access. Like you brought up the example of contact lenses. If your prescription's expired and you need to get a hold of your eye doctor, but the CDC has recommended that people don't go for things like regular prescription renewals, well then how are you able to get a renewed prescription? And then you're using old contact lenses to try to hold out. So why aren't we encouraging people to use telehealth for things like that? Because we can, again, use this after the pandemic. So there's just so much I think that people can use telehealth for when it comes to primary care, especially like you mentioned with prescription, extending prescription refills. for now and even into the future where it makes sense. And I think it's going to be kind of neat to see where necessity is the mother of invention and all the different fields that we'll see more telehealth use in that we may not have thought of previously as a field that you could use telehealth with.
Definitely. And Courtney, just building on what you just said, why haven't we sort of gotten the low-hanging fruit before now?
Yeah, so fortunately, like I said, all the legislative changes that we've seen have been, and executive orders that we've seen have been really encouraging. But a big reason why we haven't seen this.
Courtney, your connection's kind of cutting out, at least on my end. Michael, do you want to jump in?
Yeah, I think that, you know, we haven't seen this before because in a lot of places there's been a lot of objections from existing providers to telehealth,
even local and federal, of course, regular.
We're having technology problems.
This is, of course, one of the problems.
This is why telehealth hasn't taken off before this moment. No,
I think what happens is that in certain areas there's been a lot of objection from existing providers for things that should be fairly straightforward. And one issue on a lot of state levels has been teleoptics. You know, doing redoing contact lens prescriptions online. And so, you know, the question about what happens afterwards is really important because in economics, we have a phenomenon known as hysteresis, where you sort of make a change and it never goes back to where it was before. And I think we're going to see this on telehealth too. And somebody said, you know, once people have experienced it, they sort of say, okay, this is really good. And we'll find out which things can be done remotely and which things can't.
Yeah, I think data collection and, you know, kind of tracking outcomes is going to be really important once this is all over. But that was sort of my last question. And so if anyone wants to give any closing thoughts, you know, once the cat is out of the bag, it's hard to go back. And so how do you see telehealth changing after this crisis is passed? And everyone, just if Michael, you want to start, and then we can go to Courtney and Krista.
I do think it's important to have evidence-based assessments of what worked and what didn't. You know, my sense is that there's going to be a lot of areas where people say, "Yeah, this is really great. This worked," and then there's going to be some areas where people say, "This is not quite right." But getting the patients up to speed on telehealth, getting the infrastructure up to speed, and also getting the providers up to speed, it's hard to go back once you've done that.
Yeah. Courtney, do you have, you know, I don't know if your connection's working a little better, but do you have any thoughts on how this is going to impact telehealth moving forward?
Yeah, sure. So I'll try this again.
We can hear you better now, so we're good.
Sorry.
Oh, we can hear you better now, so we're good.
Great. Yeah, obviously internet connection is very important, right? So I think that kind of what Michael said, I think once we get, you know, patients and providers on board, like the pandemic is really, I think, just really speeding up the process of adjusting to using telehealth. And so I think that hopefully once we see people able to use telehealth, able to get insurance coverage for telehealth services, providers are able to be reimbursed, and once this becomes a little bit more of just our standard, I think that we're going to see how telehealth can actually impact people and not just in times of emergency, and that they're going to be able to access more care that they couldn't previously. And something we didn't touch on, and I won't elaborate on too much, but, you know, in rural areas where people don't have access to doctors in times of normalcy, you know, getting them on board with telehealth services means they're going to have overall better access to healthcare. And so I think that that's really encouraging, and hopefully some of these changes stick so that these people are better able to get the care that they need wherever they are.
Thank you. Krista, do you have any sort of closing thoughts of what this means after COVID-19?
Yeah, for any of you who have the ability to collect data, we definitely need data to bring to the Congressional Budget Office and Congress generally. And you know, I'm hopeful that everybody who has experienced telemedicine and likes it should tell their members of Congress.
Thank you. And thank you everyone for dialing in. We like to keep these short and brief, so we'll go ahead and end our call now. If you have any questions, please feel free to follow up. We will also have a number of resources available on our website after the call is over. So please check out progressivepolicy.org and let us know if you have any questions. Thank you, everyone.
Thank you.